So as you can appreciate over here, dysgerminoma is comprising of different kinds of nest. Can you appreciate this one nest? This is another nest. Yes. So dysgerminoma is comprised of several different nests or groups of tumor cells. Okay. And in between, they are separated by a fibrous septa. I hope everyone can appreciate this fibrous septa. This is the basic arrangement under the scanner view that you are going to appreciate. This is the fibrous septa that we see over here. Okay. Now, what we see that the fibrous septa over here, they are populated by a group of small lymphocytes. This is characteristic feature of dysgerminoma. This is the characteristic feature of dysgerminoma. Okay. So you see nests of tumor cells which are separated by fibrous septa containing small lymphocytes. Coming to the individual tumor cells. Now, this is another image saying the same thing. So you are having sheets of tumor cells which are actually separated from each other by a fibrous septa which is containing lymphocytes. So this is the first thing that you are going to appreciate. The second thing is that you are going to appreciate is the nature of the cells. So these cells, these are certain terms. So these cells are polygonal in nature, number one. They are having a clear to granular cytoplasm. So I hope you all can appreciate. So they are polygonal. Yes, they are polygonal. Yes, they are having some places, they are having some eosinophilic granular cytoplasm, but at places they are clear. Why are they clear? Because they contain glycogen. And how do we prove that the glycogen is present? If you stain with PAS, they are going to show positivity for glycogen. So these cells which are polygonal and these cells are containing abundant clear to eosinophilic granular cytoplasm. And very importantly, the nucleus. The nucleus is not much pleomorphic. The nucleus is characteristically round, but they are vesicular. What is the meaning of vesicular? That the nucleus is again containing a prominent nucleoli, as you can appreciate over here. And you can appreciate here and everywhere else you can appreciate. So this is how you start from the scanner view, and this is how you go to the high power, and then you appreciate all these different features. This is the central fibrovascular space. Okay, so there is a glomerulus like structure. So this is basically that we see over here is a glomerulus like structure as we appreciate. So over here, the characteristic histological feature is the glomerulus like structure composed of a central blood vessel, as we can see, the central blood vessel, which is enveloped by a tumor cell. So you can see they are enveloped by this layer of tumor cell. Yes, everyone can appreciate this layer of tumor cell. And around that, there is an empty space. Yes, and around that, again, they are enclosed by the same tumor cells. Okay, this is what is called as a Schiller dual body, which is characteristic of yolk sac carcinoma. Good evening, everyone. Today, we are going to understand about the germ cell tumors of the ovary. Starting with the classification of germ cell tumors. So there are different kinds of germ cell tumors, and out of them, we are going to read some of the most important ones. The first is dysgerminoma, yolk sac tumor, embryonal carcinoma, polyembryoma, choriocarcinoma, teratoma, immature teratoma, neuroectodermal tumors, monodermal teratoma, mixed germ cell tumor, gonadoblastoma, mixed germ cell sex cord stromal tumor, unclassified, and unclassified germ cell tumor. Out of these, teratoma, the benign cystic teratoma, more specifically, it is the most common ovarian neoplasm. So most common, any single ovarian neoplasm is benign cystic teratoma. And the most common malignant ovarian germ cell tumor, ovarian germ cell tumor is your dysgerminoma. Now, let us understand about few important features of germ cell tumors. Now, germ cell tumors, they constitute around 15 to 20% of all the ovarian tumors and includes multiple subtypes. Now, most of them, they are benign cystic teratomas and they occur mainly in children and young adults. Okay. Now, sometimes they might show malignant behavior also, but most of the germ cell tumors are benign in nature. Okay. Now, very importantly, the germ cell tumors are very much similar to the germ cell tumors involving the male testis. Now, the neoplasms in this group are mainly derived from the different kinds of germ cells. Okay, mainly the germ cells. Now, some of these germ cells, they are undifferentiated cells, giving rise to dysgerminoma and embryonal carcinoma, while others, they show a differentiation towards either embryonic or extraembryonic line. So those which are showing differentiation towards embryonic germ cells, they give rise to teratoma, and those towards the extraembryonic part, they give rise to choriocarcinoma and yolk sac tumor. So as I told you, some of the germ cell tumors, they are very undifferentiated, giving rise to either dysgerminoma or embryonal carcinomas. Okay. Very importantly, some of them that shows differentiation that into the embryonic structure, some of them that differentiate like embryonic structures, they give rise to teratoma, whereas those which are differentiating along the lines of extraembryonic structures, they give rise to non-gestational choriocarcinoma and yolk sac tumor. So dysgerminoma, as we are going to see, it is the ovarian counterpart of testicular seminoma. It is the ovarian counterpart of testicular seminoma, and it is accounting for approximately 2% of all the ovarian cancers and approximately 50% of all the malignant ovarian germ cell tumors. So very importantly, dysgerminoma, it is the most common malignant ovarian germ cell tumor, most common malignant ovarian germ cell tumor. Okay. Now they occur basically in childhood, but 75% of dysgerminoma occurs in the second or third decade of life. Okay. It occurs in the second or third decade of life. Okay. Now, most of these tumors, they do not have any endocrine function, and a few of them might produce beta HCG. Now, that beta HCG production is attributed to the presence of syncytial trophoblastic giant cells. Now, this is very non-specific, and syncytial trophoblastic giant cells might be present in other germ cell tumors like embryoma, like embryonal carcinomas as well. Now, like seminoma, dysgerminoma shows positive markers like OCT3, OCT4 and NANOG, and they are also positive for activating mutations in the KIT gene. So this becomes very useful and important molecular diagnostic markers of dysgerminoma. Okay. Now, very importantly, as I already mentioned, it is a tumor of children and young women, average age being 22 years of presentation. And approximately 20% of the malignant ovarian tumors are detected during pregnancy. They are dysgerminomas only. So remember, dysgerminoma is the most common malignant ovarian germ cell tumor. The typical presentation is with abdominal distension, abdominal mass, and abdominal pain. Very importantly, the serum LDH levels are elevated, and it can serve as a useful marker of dysgerminoma. Now remember, if instead of LDH, you are having other elements, for example, increased levels of alpha fetoprotein, or for example, you have increased levels of HCG, which is way above the roof, then they are pointing towards other germ cell tumors. So for example, alpha fetoprotein is suggesting yolk sac tumor. For example, increased levels of HCG is suggesting choriocarcinoma. So we are going to discuss more about this in the later part of the lecture. So as I told you, dysgerminoma, it is the most common malignant gonadal tumor in patients with gonadal dysgenesis. So just remember a few things. It is the most common malignant ovarian germ cell tumor, most common malignant gonadal tumor in patients with gonadal dysgenesis, also the most common malignant ovarian tumor which is detected during pregnancy. So all these histories are very important when you get an exam slide. Now, dysgerminoma confined to the ovaries, that is stage 1, at diagnosis, they are confined to the ovary in 60 to 80% of the patients, and they are unilateral. Now, they metastasize via the lymphatics into the para-aortic lymph nodes, okay, with subsequent spread to the mediastinal lymph nodes, and by transperitoneal route, they might involve the peritoneum as well. The 5-year survival rate for dysgerminoma stage 1 is greater than 90%, okay? And those that have extended beyond the ovary, the overall survival is around 80%. So coming to the gross and the microscopic picture, as it is a malignant ovarian tumor, it will be large in size. So large solid tumor measuring 10 centimeters in diameter. On cross section, they are fleshy, homogeneous or nodular. But remember, hemorrhage and necrosis will be common because it's a malignant tumor. Now, very important, let us discuss about the microscopic picture. So as you can appreciate over here, dysgerminoma is comprising of different kinds of nest. Can you appreciate this one nest? This is another nest. Yes. So this germinoma is comprised of several different nests or groups of tumor cells, okay? And in between, they are separated by a fibrous septa. I hope everyone can appreciate this fibrous septa. This is the basic arrangement under the scanner view that you are going to appreciate. This is the fibrous septa that we see over here. Okay. Now, what we see that the fibrous septa over here, they are populated by a group of small lymphocytes. This is characteristic feature of dysgerminoma. This is the characteristic feature of dysgerminoma. Okay. So you see nests of tumor cells which are separated by fibrous septa containing small lymphocytes. Coming to the individual tumor cells. Now, this is another image saying the same thing. So you are having sheets of tumor cells which are actually which are separated from each other by a fibrous septa which is containing lymphocytes. So this is the first thing that you are going to appreciate. The second thing is that you are going to appreciate is the nature of the cells. So these cells, these are certain terms. So these cells are polygonal in nature, number one. They are having a clear to granular cytoplasm. So I hope you all can appreciate. So they are polygonal. Yes, they are polygonal. Yes, they are having some places, they are having some eosinophilic granular cytoplasm, but at places they are clear. Why are they clear? Because they contain glycogen. And how do we prove that the glycogen is present? If you stain with PAS, they're going to show positivity for glycogen. So these cells which are polygonal and these cells are containing abundant clear to eosinophilic granular cytoplasm. And very importantly, the nucleus. The nucleus is not much pleomorphic. The nucleus is characteristically round, but they are vesicular. What is the meaning of vesicular? That the nucleus is again containing a prominent nucleoli, as you can appreciate over here. And you can appreciate here and everywhere else you can appreciate. So this is how you start from the scanner view, and this is how you go to the high power, and then you appreciate all these different features. Okay, so this is how microscopically you are going to describe the slide of a dysgerminoma. So just to say whatever I have said, the tumors are usually polygonal with a very distinct cell membrane and abundant granular to clear cytoplasm. Now, the clear cytoplasm can be attributed to the presence of glycogen, the cytoplasm of which can be stained positive with PAS. The nucleus, as I showed you, was central, round, and vesicular, containing prominent nucleoli, and mitotic activities were numerous. Now, the cell, if you can appreciate, they were growing in nest or in lobules or in trabeculae, all of them separated by a fibrous septa, which is containing lymphocytes. Now, in addition to this, you might also see epithelioid cells, multinucleate Langhans giant cells. Along with that, you might also see some granulomas. So yes, granulomas are very commonly seen in case of dysgerminoma, and this is a very important Viva exam question. Now, the neoplasms, now some kind of dysgerminoma might show a greater degree of atypia as compared to their normal counterpart. Such kind of dysgerminomas are also labeled as anaplastic dysgerminoma. Now, as I told you, syncytial trophoblastic giant cells, they might be present in any other kind of germ cell tumor. Okay, so around 3% of dysgerminomas can contain some syncytial trophoblastic cells, and if present, they are going to secrete beta HCG. Okay, that is the only. But remember, it doesn't have any implication on the prognosis of dysgerminoma. Okay, so I hope dysgerminoma is clear to everyone. Okay, let me just discuss one more important point over here. Okay, now coming into the immunohistochemistry and the molecular pathology. So I have already discussed. So chromosome 12p abnormality, especially isochromosome 12, is the most common and characteristic finding of malignant germ cell tumor, especially in case of dysgerminoma. Also, I have already discussed the presence of KIT mutations. These are important Viva questions and will be asked. Now, the staining, the immunohistochemistry of this tumor is divided into two parts depending on the staining. One group of antibodies, they are staining the membranes, okay, strongly and diffusely staining the membranes as well as the cytoplasm. So this group of antibodies, they are PLAB, that is the placental alkaline phosphatase, CD117, that is also the c-KIT, and D240. All these three, they show strong and diffuse membranous staining. Whereas OCT4, NANOG, and SAL4, they stain positive for the nucleus, strong and diffuse staining for the nucleus. So you have to remember the immunohistochemistry of the germ cell tumors, one of the most important questions which is asked. Now, always remember dysgerminoma, they are MR negative. So when we are saying MR negative, we are differentiating it from epithelial tumors. Yes, we have read about the epithelial tumors in the previous lecture. So we are differentiating it from them. Now, positive staining for HCG, it is seen in syncytial trophoblastic cells only. Now, remember, as alpha fetoprotein, glypican 3, and SOX2, CD30, these are not, these are coming out to be negative. Why am I doing this stain? Because these are positive in yolk sac tumor, whereas the SOX2 and CD30, they are positive in embryonal tumor. So in a panel, when you are suspecting a germ cell tumor, you can include these markers so as to exclude other germ cell tumors like the yolk sac tumor and embryonal tumor. Okay, and the tumor infiltrating lymphocytes are predominantly the T cells. So I hope dysgerminoma is clear to everyone. Yes. Any doubts with regard to dysgerminoma? Anyone is having any doubt with regard to dysgerminoma? Yes. It is a very, very important exam question, and it is asked always. One slide will be there from germ cell tumor, especially dysgerminoma is there. Okay. Any doubts? Anyone is having? Okay. Next, we are going to go to yolk sac tumor. Now, yolk sac tumor previously was also called as an endodermal sinus tumor. Okay. It is again a malignant germ cell tumor. And over here, the differentiation is just like the yolk sac structures. Okay. Now, very importantly, yolk sac tumor, it is the third most common germ cell tumor of the ovary and comprises 1% of all the ovarian malignancies. Okay. Now, remember, this particular information has been given in Robbins, and this particular information has been given in Flethchers. In WHO, they have not mentioned anything in particular. So accordingly, if anyone asks you, according to Flethchers, they are the second most common malignant ovarian tumor of germ cell origin, and it is thought to be derived from the malignant germ cells that are differentiating along the extra embryonic yolk sac lineage. Okay. Now, as I told you, as other germ cell tumors, yolk sac tumor is also predominantly involving children and young women. Okay, always remember this. And the mean age of presentation is around 19 years. Again, just like any other germ cell tumor, they are also presenting with abdominal pain, abdominal enlargement, or abdominal mass. Now, very importantly, such patients are showing high levels of serum alpha fetoprotein. Okay, and they might also show an increased level of CA125. Now, yolk sac tumor have a worse prognosis when we compare it with dysgerminoma. So yolk sac tumors, which are limited to the ovary, are diagnosis in about 50% of the patients. Okay, so they are limited to the ovary at the time of diagnosis in only 50% of the patients. So that means, whereas in case of dysgerminoma, more than 90% patients, it was limited to the ovary. So again, the diagnosis over here or the prognosis becomes a little bit bad. So tumors confined to the pelvis are seen in 10% cases, whereas remaining 40% have widespread metastasis. So a large group of patients presents with metastasis in case of yolk sac tumor. Now, very important, as I told you, the serum AFP level can serve two purposes. Can be used to monitor the treatment as well as to detect the tumor recurrence. Okay. Now, before the availability of chemotherapy, the prognosis was quite dismal, but now the prognosis is quite better after the combination chemotherapy that is available. So just like any other malignant germ cell tumor, these tumors are also showing areas of hemorrhage and necrosis. Okay. So coming to the microscopic pathology, it's very important to understand that the yolk sac tumor is containing a mixture of patterns. So this is the first important question that is asked to you. What are the different kinds of pattern that you see in a yolk sac tumor? So the first pattern that should come out from your mouth is the microcystic or the reticular pattern. Now, what is this pattern? This pattern is basically containing different microcystic spaces, as you can appreciate over here, of different size and shapes, as we see over here. Okay, and that is spread out. So what you are going to see, usually you will never encounter a yolk sac tumor, in isolation. You will always see yolk sac tumor or embryonal tumor or embryonal carcinoma as a part of a mixed germ cell tumor. So in a mixed germ cell tumor, you will suddenly see an area which is quite, haphazard, which is quite, clear, and you can see multiple spaces like this. Okay. Once you encounter this space, you think that this is the yolk sac component. Okay, so this is the most commonly encountered microcystic or the reticular pattern. So first you have to understand this pattern. So what is this pattern? This pattern is comprised of certain microcystic spaces. If you will see closely, they are lined by a flattened epithelium of cell, also called as a flattened layer of cuboidal cell. And this layer of cuboidal cell or flat epithelium contains nucleus which is hyperchromatic, okay, which is hyperchromatic. Okay, so this is how we see, appreciate. So this is another pattern that is called as the endodermal sinus pattern. Okay, endodermal sinus pattern. Now this pattern comprises of multiple glands or papillae. Now a papillae is exactly the same that I am talking about, wherein you see a fibrovascular core. Now classical thing about this endodermal sinus pattern is the presence of something called as Schiller-Duval body, which will be asked to you in the Viva. What is a Schiller-Duval body? It is actually a papillae. This is the central papillae. Now, this papillae is comprising a fibrovascular core surrounded by, now over here it is not very apparent, but over here a layer of tumor cell, flat tumor cell layer is present surrounding the papillae. And then there is a empty space that is again surrounded by a layer of a tumor cell. This is what is called as a Schiller-Duval body. Let me just show you another diagram so as to make you understand. This is the central fibrovascular space. Okay, so there is a glomerulus like structure. So this is basically that we see over here is a glomerulus like structure, as we appreciate. So over here the characteristic histological feature is the glomerulus like structure composed of a central blood vessel, as we can see, the central blood vessel, which is enveloped by a tumor cell. So you can see they are enveloped by this layer of tumor cell. Yes, everyone can appreciate this layer of tumor cell. And around that, there is an empty space. Yes, and around that, again, they are enclosed by the same tumor cells. Okay, this is what is called as a Schiller-Duval body, which is characteristic of yolk sac carcinoma, not seen in every yolk sac tumor, and basically it is seen in the endodermal sinus pattern. That is why the yolk sac tumors are also called as endodermal sinus tumors. Is this very clear to everyone? Any doubts over here? Yes? Okay. Now, this is another pattern of the yolk sac tumor called as the polyvesicular vitelline pattern. Now, when we look at this polyvesicular vitelline pattern, again, you will see that there are spaces, which are huge spaces, and they are lined by two different kinds of epithelium. Over here, you have a layer of columnar tumor cells, whereas over here, you have a layer of flattened cells. Okay, and this flat cells, basically these are surrounded by a stroma which is immature. So there is an immature stromal component also over here, which is resembling the polyvesicular vitelline pattern. The next pattern is the endometrioid like variant, wherein you can see endometrioid like glands. But mark it, these glands, they do not stain positive for ERPR. In fact, they are going to stain positive for AFP. Okay, that is the yolk sac tumor component. Now, what very important feature of this is that such endometrioid-like pattern of yolk sac tumor, if you appreciate, they are containing subnucleolar vacuoles. Beneath the nucleus, there are some vacuoles, which is called as conspicuous subnuclear vacuoles is present in this endometrioid pattern. Okay. Now, again, this is a reticular pattern, but why have I showed you? You can see multiple eosinophilic droplets. Okay, multiple eosinophilic droplets. Usually, this eosinophilic droplets, they will stain positive for alpha fetoprotein. That is, they are regarded as alpha fetoprotein. Okay, so they can be both extracellular or they can be both intracellular as well as extracellular. Okay, so this is about the yolk sac tumor, and this is about the different patterns of yolk sac tumor. Let me just go through the important points. So the two most and distinctive patterns, one is the reticular or the microcystic pattern that I had shown you, and the endodermal sinus pattern containing the Schiller-Duval body. So reticular pattern, as I told you, they are comprising of microcystic spaces lined by a single layer of flat or cuboidal cell. Whereas the endodermal sinus pattern, also called as a festoon or pseudopapillary pattern, okay, it is basically comprising of Schiller-Duval bodies, the glomeruloid bodies, okay, in which the fibrovascular cores are covered by columnar tumor cells, and this particular arrangement is actually projecting into a clear space which is again lined by the same tumor cells. Okay, so they are a characteristic finding in this pattern, that is the endodermal sinus pattern, and they're observed in 2/3 of the cases. So they are diagnostic of yolk sac tumor. Okay. Now this pattern is again closely associated with other patterns. That is the alveolar glandular pattern is another pattern. And again, in this endodermal sinus pattern, we see the presence of eosinophilic hyaline globules that I showed you, which are PAS positive, okay, which are PAS positive, and a characteristic finding seen in the yolk sac tumor. Okay. Then there are other patterns also. As I told you, the polyvesicular vitelline pattern is there. I'm not going to discuss again how they look. There's a hepatoid pattern where you have a solid sheet of cell. Okay. You have a glandular pattern very similar to the endometrial cells, okay, or the intestinal pattern as well. So I have already explained you have a single layer of columnar cells which are lined by cells with showing subnuclear cytoplasmic vacuoles. Okay. Coming to the immunohistochemistry of this part, very, very, very important. Most of them, they are positive for alpha fetoprotein, but this answer, it is an undergraduate level answer, alpha feto level protein. You have to speak about other markers. So the additional markers that you should know is glypican-3. They will ask you Sol4, okay, very important, glypican-3, Sol4 and alpha fetoprotein. A new marker is your hepatocyte nuclear factor 1 beta. Okay, remember they are cytokeratin positive, but remember, unlike other epithelial tumors, they are negative for EMA. Remember, they are negative for EMA. As I told you, DYSGERMINOMA is also negative for EMA, as I told you, just to differentiate from other epithelial tumors of the ovary. Okay, so the IHC features alpha fetoprotein, they are positive, but you also have to remember glypican-3, Sol4, and hepatocyte nuclear factor 1 beta. Is this clear to everyone? Any doubts with regard to yolk sac tumor? Okay. Then we are going to understand about the embryonic cell carcinoma. Now, regarding the embryonic cell carcinoma, let us try and understand. Now, basically, they are very similar to the embryonic carcinoma of the testis. And again, just like any other germ cell tumor, they are predominantly seen in children and young women. The average age of presentation is 15 years, and just like other malignant germ cell tumors, they are presenting with abdominal pain, palpable abdominal mass. Okay, very, very, very important thing. This tumor, again, just like dysgerminoma, this is also containing a lot of syncytial trophoblastic cell. So usually they are going to be positive for beta HCG. So a young patient coming to you with beta HCG positivity, okay, you should suspect embryonal carcinoma in such patients. So usually most patients, they have a positive pregnancy test. I hope everyone knows that the pregnancy test is based on the beta HCG level. Okay. And very important, around 50% can present as a premenarcheal patients. They can have precocious pseudo puberty also. So this is also one other type of presentation. Remember, any of the malignant germ cell tumors, they are never bilateral. Okay, they are always unilateral. Now, without chemotherapy, this tumor used to be rapidly fatal, but recent post-operative cisplatin-based chemotherapy is basically showing complete success. So the prognosis has been improved a lot. Okay, so let us see the gross and microscopic picture. So just like any malignant germ cell tumor, they are also large, fleshy, hemorrhage, necrosis tumor. Now, microscopically, it resembles very much. I am just going to start with the microscopy first. So microscopically, if you see, they look very similar to which germ cell tumor? Yes, can anyone tell me? They look very similar to dysgerminoma. Yes or no, everyone? So how do you differentiate? What is the difference? If you remember, in dysgerminoma, I was telling you that the nucleus is round, the nucleus is monotonous, it is not pleomorphic. But look over here, look at the nucleus. Look at the nucleus. They are highly pleomorphic. They show high degree of nuclear pleomorphism as compared to your other tumor, as compared to your dysgerminoma. So these tumors are highly anaplastic, sheet-like growth of anaplastic, anaplastic tumor cells. That is the classic definition of an embryonal carcinoma. Again, there is no fibrous septa which is present over here. So you will not find a fibrous septa dividing the tumors into nests. You will not find any kind of inflammatory cell that we were seeing in dysgerminoma. So one very important differential diagnosis is this. So the microscopic picture, okay, the tumor is comprising of large vesicular nuclear with coarse chromatin. The nucleus is large and they show marked nuclear pleomorphism. So this is how it is different from a dysgerminoma. Again, the tumor cell contains abundant amount of amphiphilic to clear cytoplasm. The tumor cell, they grow in nest and sheets, but remember there is no fibrous septa which is dividing these tumor cells. As I told you, because they are secreting huge amount of beta HCG, and remember beta HCG always, it is a very non-specific marker, because most of the germ cell tumors can contain a proportion of syncytial trophoblastic cells which will secrete beta HCG. So remember, most embryonal carcinomas, they contain syncytial trophoblastic cells, okay? But remember, no cytotrophoblastic cell is seen. Always remember, the stroma of this tumor is quite loose and edematous. And as I told you, remember, yolk sac tumor, embryonal carcinoma, they will never be present singly. They will always be present as a mixed germ cell tumor. Remember, always admixed with yolk sac tumor or an immature teratoma. Okay, always like that. It is rarely seen in the pure form. Okay. Immunohistochemistry, as I told you, immunohistochemistry becomes very, very important over here. Remember, there is no staging for MR. That means this is how we differentiate it from epithelial tumor. Now, embryonal carcinoma shows positive staining for nuclear markers like OCT4, SAL4, SOX2. Now you will say me that, sir, OCT4 is also positive in dysgerminoma and SOL4 is positive in dysgerminoma as well as yolk sac tumor. So these two markers are, we can say that they are overlapping. So what is the marker which is very different for embryonal carcinoma? It is CD30. Very, very important finding. The first marker or the most important marker that is differentiating is your membranous staining of CD30, which is not present in any other germ cell tumor. Another very important marker is SOX2, which is again very, very specific for embryonal carcinoma. So is this point very clear to everyone about the immunohistochemistry? Yes? Okay. Yes. So I hope we have discussed most of the important points. Now we are coming to choriocarcinoma. So pure ovarian choriocarcinoma, as I told you, it is extremely rare. Even embryonal carcinoma, even yolk sac tumors, all these are very rare. Okay, remember, less than 1% are choriocarcinomas, and remember, they are most commonly present as a component of a mixed germ cell tumor. As I have already explained, these are very common in children and young women. Very, very rarely it can occur, as a part of epithelial tumor of the ovary in a post-menopausal patient. Okay, in that case, it becomes non-gestational. Okay, now the clinical presentation is with abnormal pain, abnormal vaginal bleeding. A pregnancy test is positive. Again, as I told you, pregnancy test, if it comes out to be positive, it is indicating a presence of a germ cell tumor. It might be any. And as I told you, syncytial trophoblast, this is basically a tumor which is of a syncytial trophoblast. So over here, beta HCG will be there. But that is also seen in dysgerminoma, also seen in embryonal carcinoma, also seen in yolk sac tumor. So, but in this case, you are going to have positivity for beta HCG, and they may also present with precocious pseudopuberty. Again, just like other germ cell tumors, these are unilateral. These are unilateral. Now remember, the prognosis of the patients with gestational choriocarcinoma, as we are discussing, that occurs in children and young women, they are quite different with that with non-gestational, which occurs in post-menopausal women. Now remember, those which are of germ cell origin, they are more aggressive and they are less chemosensitive in nature. Okay, just remember this very important part. So it is very, very important to see, to determine whether an ovarian choriocarcinoma is whether of gestational or it is of germ cell type. If it is of germ cell type, that is arising in the post-menopausal women, in that case, the prognosis becomes very, very bad. Whereas the prognosis for one arising in children and young women, that is the gestational variety, the prognosis is quite better. Okay, so in young women and childbearing age group, the gestational choriocarcinoma is equally as likely as germ cell choriocarcinoma. Just remember this point, very, very common. Okay. Now let us see. Yes, if you do not give any treatment over here, the patient might be fatal. Okay, unresponsive to chemotherapy, and they are fatal. Now, looking at the gross pathology, as we see, again, the tumor over here is hemorrhagic and necrotic, as we had discussed. Very important is this tumor microscopically shows maximum amount of hemorrhage and necrosis. And you will see syncytial trophoblastic cells as well as cytotrophoblastic cells, which are growing in a haphazard fashion. So if you see over here, this is the These cells, if you see, which is having a vesicular nucleus and they have a very clear cytoplasm, pale cytoplasm with a vesicular nucleus, these are the characteristic cytotrophoblastic cells, as we can appreciate over here. Whereas those cells which you can see like this, you can see multiple nucleus is present, basophilic cytoplasm is there. These basically constitute the syncytial trophoblast. Okay, syncytial trophoblast containing multiple small nucleus with a syncytium of basophilic cytoplasm. The last and the most important germ cell tumor, very important for your exam, is your teratoma. Now remember, benign cystic teratoma, it is the most common ovarian neoplasm overall, comprising 25% or more of all ovarian tumors. Now most of the teratomas, okay, they have a 46XX karyotype and they appear to be derived from post-meiotic germ cells. Now there are numerous benign and malignant variants of teratoma of the ovary. Now, teratoma is in which one element greatly predominates is called as a monodermal teratoma. Example is your struma ovary. Example is your struma ovary. Okay. So, mature teratoma. So, first we are going to start with mature teratoma. Then we are going to discuss about immature teratoma. So, mature teratomas, they are generally cystic in nature, and they are composed of various mature tissues from ectoderm, mesoderm, as well as endoderm. They can occur in all the ages, but usually they are found in women of reproductive age group between 20 to 50 years, and only 20% women, they are post-menopausal. Most of the patients are asymptomatic at presentation. Now, mature teratoma, it is a benign neoplasm, so it is basically treated conservatively. Now, they might also be associated with other paraneoplastic syndrome. One very important, which is asked in exam, is inflammatory limbic encephalitis. Around 1% of the dermal cyst, they can undergo transformation into some or other kind of malignancy, most commonly into squamous cell carcinoma, but can be other cancers also. So benign teratoma, that is very important when you are carrying out the grossing of teratoma. It is very important you understand the grossing. So whenever you see an ovarian tumor, or whenever you see a dermoid cyst, or you are suspecting it is a dermoid cyst, you are watching a cartilage or a tooth, always you should take sections from the solid areas, because the solid areas might contain some bad thing. So whenever you see any solid area and you're suspecting a germ cell tumor, the solid areas need to be sampled, because the immature part or the bad part might be there hidden in the solid part. So benign teratomas, they are nearly always cystic, approximately 7 to 8 centimeters in diameter, and they are bilateral in only 10 to 15% of the cases. So majority of the malignant germ cell tumors that we have seen, they are unilateral in nature. So this is your mature cystic teratoma. You can see this is a mass containing hair, mixture of tissues are seen, and there is hair, and it is cystic. It is an open space. It is multicystic. One space here, one space here, one space here. It is multicystic in nature. Okay. Now, very importantly, if you see over here, if you find, you might also find cartilage, bone, and teeth over here. Any dense solid region in an otherwise cystic teratoma is unusual. So in a benign cystic teratoma, usually you will not see any dense solid area. And if you see, you have to section that area and rule out any immature component if it is present. Okay. So let us look at the microscopic picture. Now, microscopic picture is very simple. Okay, let me just show you the microscopic picture. So usually, as I told you, they will be comprising a mixture of ectodermal, mesodermal, and endodermal elements in an organized fashion. So there is no haphazard arrangement. And at least tissues from 2 germ layers has to be present. They comprise 2/3 of the mature teratomas. So the ectodermal derivatives includes the skin, hair follicles, sebaceous and sweat glands. Okay, and they are the most common. They are they form the most common histological picture. Okay, and therefore they are called as dermoid cysts. Someone asked me in the previous lecture, are dermoid cyst and cystic teratoma the same thing? Now, why they are called as dermoid cysts? Because the most common element of the benign cystic teratoma are the dermal elements. That is why we are using the term dermoid cyst. Okay. Other ectodermal elements that can be present over here is the neural tissue. Usually the glial tissue, the nerves, and the dental structures are there. The common endodermal tissues include digestive tract mucosa or respiratory lining, the pseudostratified ciliated epithelial lining, the thyroid tissue might be there. The most common mesodermal derivative you will find adipose tissue, or you might find the skeletal tissue, or smooth muscles, or bone cartilage, or loose connective tissue. These forms the mesodermal derivative. Okay, male tissues such as the prostate are occasionally present, can be present also. Okay, now sometimes you might just see a single tissue which is going to predominate the entire picture. For example, if a tumor is containing, if a benign cystic teratoma is just composed of a thyroid tissue, in that case we are calling it as struma ovary. Okay, this is a type of monodermal teratoma. Similarly, sometimes they might also be comprised of just carcinoid. In that case, they are called as struma carcinoid. So both of them are actually form of monodermal teratoma. So this is a very important diagram that I want to show you. You can see the ectodermal elements. Okay, this is the stratified squamous epithelium. This is the keratin secreted by the same. Here, what is this? This is the hair follicle that we can appreciate. And what are these? Yes, can anyone tell me what are these? These are the mature sebaceous glands that you see in this particular picture. So you can see the skin and epidermal appendages with the stratified squamous epithelium, hair shafts, and the sebaceous glands which are underlying. Okay. Now, very importantly, secondary malignancies can arise in 1% of these tumors, and mostly they are arising in post-menopausal women. Now remember, tumors are confined to the ovary in 40 to 75% of the patients, and they are having a favorable prognosis. The outcome is more unfavorable in women with advanced tumors, as we have seen. Now, what other tumors does develop over here? So I just wanted to tell you, not only malignant tumors, but also other benign tumors can be associated with benign, cystic teratoma or with teratoma. So among the benign neoplasms, nevus, sebaceous adenomas, other cutaneous adnexal neoplasms, benign salivary gland tumors, meningiomas, glomus tumors. These are all the benign tumors that arises. And sometimes in situ carcinomas also arise, like squamous cell carcinoma in situ and Paget's disease. So these are the benign tumors which are arising. And sometimes malignant tumors also arise. So among the malignant tumors, around 85% of the malignancies are composed of invasive squamous cell carcinomas, most of which are moderate to poorly differentiated. Other malignant tumors can be cutaneous carcinomas like basal cell carcinoma or sebaceous carcinomas. You can also have melanomas or adenocarcinomas. Various types of sarcomas can also arise. Okay, so this is the secondary malignancies which are arising in case of a teratoma. Now, this is basically a squamous cell carcinoma, as you can appreciate, is a keratinizing squamous cell carcinoma arising as a secondary neoplasm in a benign cystic teratoma. So it can arise, okay? You can have all the benign components of a teratoma, and along with that, in one area, they might contain a secondary neoplasm. Now, immature malignant teratoma. Now, this becomes a very, very important exam question, very, very important exam slide also, okay? A lot of questions are based on this particular slide. So let us see. Now, these are basically rare tumors that differ from benign teratomas in that the component tissues, they resemble the embryonal and immature fetal tissue, as I told you. Okay, so they are resembling the embryonal tissues, like the immature tissue. Again, they are seen in the pre-pubertal adolescents and young women, and the mean age is around 18 years. So most of them, they are localized at diagnosis, and again, bilaterality is not seen. It is a unilateral tumor. So grossly, if we see, immature teratoma is predominantly composed of solid unilateral tumor, averaging around 18 centimeter in diameter. Microscopically, very, very important, before I go over there, you are going to see most commonly the primitive neuroepithelium. Can you appreciate the primitive neuroepithelium? Yes, everyone. These are nothing but immature hyperchromatic neural tissue. Some of them presenting as a neurothelium, as we can appreciate over here. Some of them can present as immature cartilage, immature bone, muscle, or other elements. So the most important feature over here is a haphazard distribution. Okay, so there is no organized growth pattern as it was seen in benign cystic teratoma. Usually the ectodermal and the mesodermal derivatives predominate the picture. The most important part, as I told you, is the immature neuroectodermal element that I highlighted. It is the easiest immature tissue to recognize and quantitate. That is why the recognition of this immature neurothelium becomes very, very important. That is why the the classification and the grading of the immature teratoma is based on the amount of primitive neuroepithelium. Okay. Now, basically, these include sheets of mitotically active immature neuroepithelial cells, which is containing hyperchromatic nucleus, if we can appreciate. These might just be present in sheets, as we can appreciate. They are present just in sheets, or they might be present in the form of immature tubules. So see, this part, the cell is present in an immature neural sheets. Okay, neurothelium, immature cells. Okay, and over here they might also be present in the form of tubules, which we called as immature tubules. Okay, okay, we can appreciate over here immature tubules. Okay, so they can be present as sheets and nests of neuroblasts containing anuclear fibrillary zones and forming what is called as homarite rosettes. So sometimes these neuroblasts, as we can appreciate, these neuroblasts, they are surrounding a neural tissue. Okay, so these are small round neuroblasts, as you can appreciate over here. Okay, they are surrounding a primitive neural tubule. They are forming a primitive neural tubule. See over here, these neuroblasts, as you can appreciate, they are surrounding some neurofibrillary matrix. Okay, this is a fibrillary matrix. And what is this called as? This is a rosette called as homarite rosette. Homarite rosette, as you can appreciate over here. Okay. So you can see mitotically active immature neuroepithelial cells. You can see tubules lined by columnar embryonal cells with a stratified hyperchromatic nucleus, sheets and nest of neuroblasts containing fibrillary zones and homarite rosettes, mitotically active immature glial cells, as well as melanin pigmentation. So this is the immature neurothelium that I was talking about, the primitive neurothelium, sheets of hyperchromatic immature neural cells. Over here again, sheets plus some of them are in the form of tubules, as well, as we can appreciate over here, containing the neural cells, immature neural cells, in a stratified manner. Okay, then we are having immature teratoma over here again, the classical tubules, the primitive tubules that is formed by the neuroblast, the homarite rosettes, which is surrounding the neurofibrillary matrix, as we can appreciate over here. And not only that, the mesenchymal tissue is also immature, but because this portion is not easy to quantitate, for example, I can see this as an immature mesenchymal tissue, but you might not appreciate it as. But for example, this immature hyperchromatic cells that we see, everyone will be able to see. That is why we are grading this particular tumor in accordance with the amount of the immature primitive neuroepithelial tissue. I hope this is crystal clear. This is the histological grading of immature teratoma, which is a sure short Viva question will be asked to you. So there are three important grades. Grade 0 is not to be said, just remember grade 1, 2, 3. So grade 1, when the amount of neurothelium is not more than 1 low power field per slide. Okay. Grade 2 is when the amount of neurothelium is common, when it is not more than 3 per low power field. And grade 3, when more than equal to 4 low power field, neurothelium can be appreciated. That is it. So an important risk for the subsequent spread is the histological grading. So histological grading in case of immature teratoma is a must. Okay, grade 1 to 3. So the grading is basically based on the amount of immature neurothelium. So grade 0 is for a neoplasm completely entirely composed of mature tissues. And grade 3 is for neoplasm containing abundant amount of immature tissue. And I have already given the grading over here. Okay. So this is very, very important. Now remember one thing, just like as I told you in case of dysgerminoma, that abnormalities of chromosome 12 is very common in most germ cell tumors, especially in case of dysgerminoma. Also in case of teratomas, especially in the pure immature variety. Okay, one very important thing is that these are lacking the isochromosome 12p. Okay, these do not have this particular genetic aberration. Okay, remember. Now, immunohistochemistry has a very little role over here, doesn't play much role. So morphology plays a very important role in the diagnosis of these tumors. Okay. So is this clear to everyone about immature teratoma? Any doubts with regard to immature teratoma? Yes, anyone is having any doubts with regard to immature teratoma? Okay. Now, very importantly, the stage 1 tumors confined to the ovary is having an excellent prognosis. Whereas the high-grade tumors confined to the ovary are generally treated with adjuvant chemotherapy. So that is why you have to do the grading. So grade 1 histology, you just do the surgery, the patient will be fine. With high-grade tumors, you have to add the chemotherapy. That becomes very, very important to do the grading. Now, lastly, we are going to end by reading about the monodermal or specialized teratoma. Now remember, the specialized teratoma is rare, okay? And remarkably, specialized teratomas means when in case of a benign teratoma, one component is present in an excessive proportion. So for example, we have something called as the struma ovary and the carcinoid, okay? So struma ovary is one which is entirely composed of mature thyroid tissues, okay? And carcinoid tumors, I hope you all understand what are the carcinoid tumors. Okay, these are special tumors which are most commonly seen in the lungs, bronchus, or in the intestine. Okay, so basically, such tumors, basically, if they are present along, in the teratoma, and if they are forming the majority component, okay, then they are called as struma carcinoid. Usually, such tumors they secrete 5-hydroxytryptamine, which is causing what is called as carcinoid syndrome. Okay, so remember, we have to differentiate the primary ovarian carcinoid must be distinguished from metastatic intestinal carcinoid. Now, in case of metastatic intestinal carcinoid, remember the ovaries are involved bilaterally, whereas all the germ cell tumors, they are always unilateral. So this is a very important point of difference between the two. Again, an important viva question. Okay, so this is all about your germ cell tumors.